This conference will now be recorded.
Good morning, students. I'll start my class in 5 minutes. So today's class is about urinary lithiasis, which is also called as nephrolithiasis or urinary stones or urinary caliculi. So whenever you discuss a topic about urinary lithiasis, it is again divided into two parts. That is uh, renal caliculi and bladder stones. So they are two different things. So coming to the kidney stones are more common in 30 to third decade to fourth decade of life. They are most commonly presented in that age group of patients, and it has a very high male preponderance. So that is about 3:2, 3:1, or 2:1 ratio. Most commonly 3:1 ratio. Males are highly impacted by renal caliculi when compared to females. So it is more common in Americans than in Asians. So as an order, uh, when you take it that way, whites have the highest incidence of the upper urinary tract stones, followed by Hispanics, and then comes the uh, Asians. But in the recent decades what is happening is even in the Asian population, urinary lithiasis are gaining importance because our diet has changed. Asian diet has changed to more European style of or more American style of food. So the rate of stones are also increasing in Asian. When if you take India, Indians don't have that many cases of urinary stones, but in the last 2 decades, the cases of urinary stones are increasing rapidly. Again, geography is very important because when it is in hot and tropical climate where excessive dehydration is seen, the chances of stone formation are higher. Because when we talk about the pathophysiology, I'll say why stone formation is more in dry areas. So that comes about the climate. When comes to the then comes the occupation. So what is the importance of occupation epidemiology? So when you see a patient who is working in a hot climate, for example, miners or chefs or some engineers working in a plant, so these people are more prone to dehydration. So this again leads to stone formation in those occupations. So occupation is also very important in this. So again, the other systemic illnesses like obesity, diabetes, and metabolic syndromes can also lead to stone formation in the patients. So one of the most important factor here in obesity is subjects with the higher BMI. They excreted more calcium oxalate stones when compared to the person with lower BMI. So obesity is very important here. Then comes the systemic illnesses like chronic kidney disease and cardiovascular disease. Patients with those illnesses has again have a minor rise in incidence. So coming to that is about the epidemiology part. So the risk factors are again immobility, sedentary lifestyle, metabolic disturbances, and history of renal calculi. So another important thing is citrate level in urine. So citrate has an inhibitory effect of calcium preponderant stones in the urine. So whenever the citrate levels are high, there is a chance of low urinary tract stone formation. So again, infection is one of the predisposing factor for calcium for any type of stone. So why prolonged immobilization means because this causes decalcification of the bones, which leads to hypercalciuria, leading to stone formation. So before I go into the metabolic part of the pathophysiology, I'll say why pathophysiology, why stone formation occurs, and what are the steps involved. There are state of supersaturation. There is a state of supersaturation. What happens here is there will be a nucleation of the crystals. So these crystals grow and then they get aggregated. So without any inhibitors, these aggregation results in stone formation. So you should always remember that for a stone to be formed, the urine must always be in a supersaturated state. So, and again, supersaturation alone is not enough because there should be a presence of inhibitors. So if there are inhibitors, stone formation doesn't occur. So the examples of inhibitors are nephrocalcin, uropontin, and TAM horsefall proteins. So just write it down if you have a paper in hand. There are proteins called TAM horsefall protein, which inhibits stone formation. Then again, there is something called as the urinary glycoproteins like nephrocalcin. So these inhibitors inhibit the calcium oxalate crystal aggregation. So prevention of this crystal aggregation prevents calcium oxalate stone formation. Then again, there is osteopontin. So these also prevent the growth and aggregation of the crystals. So these are some of the inhibitors present in the urine. So one of the common sites where calcium stones originate are the subepithelial plaques, which are composed of calcium apatite, and they serve as the anchor. So nidus, what we call that as a nidus. So for any stone to form, there should be an origin point. So that happens in the subepithelial plaques. And the calcium apatite serves as an anchor. So at this point, every calcium oxalate gets aggregated and the stone grows in size. So again, this is the about the crystalline component of the stones. There is something called as non-crystalline component of the stones, which is formed by the matrix. So this is formed by combination of mucoproteins, carbohydrates, and urinary inhibitors, like which I have already said to you now. The inhibitors are nephrocalcin, uropontin, and tam horsfall proteins. This I have not included in my slides, but please note down. Nephrocalcin, uropontin, and tam horsfall protein. These are the inhibitors of stone formation. Then comes the metabolic part, which is the most important minerals are calcium, phosphorus, magnesium, and oxalate. So coming to the calcium part, so calcium absorption primarily occurs in the small intestine. This being in a 9th semester student, you should all know calcium absorption occurs primarily in the small intestine. So that is dependent on the calcium intake that you take. So that is inversely proportionate to the intake of the calcium. So 1,2,5 dihydroxyvitamin D3 is the most potent stimulator of intestinal calcium absorption. And again, what other stimulates these things are parathyroid hormone stimulates 1-alpha hydroxylase in the proximal tubule of the kidney. So this converts 25 hydroxy D3 to 125 dihydroxy cholecalciferol. So again, what the PTH parathyroid hormone does is this enhances the proximal tubular absorption of the calcium and renal phosphate excretion. So this PTH enhances calcium absorption, calcium reabsorption, and renal phosphate excretion. This is the role of PTH. And again, the intestinal oxalate absorption that is influenced by the luminal calcium, magnesium, and some bacteria, some kind of bacteria which degrades the oxalate present in there. So this I have said already. There are stages of stone formation that are supersaturation, nucleus formation, crystallization, aggregation, matrix formation, and stone. So coming to the types of stones, the most common one are the calcium dependent stones, which are calcium oxalate. They are about 40 to 60%. On KUB, they are radioisotopic. So the risk factors associated with calcium oxalate are underlying metabolic disorders like idiopathic hypercalciuric or hyperoxaluria. So these are the risk factors or etiological factors leading to calcium oxalate stones. The other type of calcium stones are hydroxyapatite stone. They constitute about 20%. They are also radiopaque. And the least common of the calcium stones are the bruchid stone. They account about 2%. So always remember 60, 20, and 2%. So that constitutes approximately about 75% of the stones are always calcium stones. And then comes the non-calcium containing stones like uric acid, struvate, cysteine, uh, trimetrin, and silica. These I have not included, but there are stones called trimetrin and silica. So they constitute about less than 1%, but uric acid, struvate, and cysteine are important because uric acid stones are again 5 to 10% common, and struvate is about 5 to 15%. Cysteine is about 1 to 3%. Of these, uric acid is radiolucent, and rest of them are mostly radio opaque. So whenever an examiner asks, or if you want to remember this to write in the exam, always remember only uric acid stones are radiolucent, the rest of the stones are radio opaque. That will be easy to remember. So coming to the oxalate stones, that is calcium oxalate stones, they constitute about 70% of the calcium content is about 70 to 80% of them. So the general appearance is always white and hard. So these also present as a stag-on caliculi in renal pelvis. So stag-on caliculi is they take the shape of the entire renal pelvis. So when we take it out, it looks like a staghorn, hence the name. Calcium oxalate stones are also present in ureter, but are very small due to these speculations present over the oxalate stones. They can cause trauma and hematuria. So these projections, which you are seeing, small medullary projections, this gave them the name called as mulberry stone. So these projections, when they come in contact with the ureter or any soft tissue of the renal system, they irritate and they cause trauma, minute trauma, which leads to hematuria. Not gross hematuria, but microscopic hematuria. When it comes to the phosphate stones, they constitute about 10 to 15%. So calcium phosphate stones occur due to infection, most commonly due to infections. Though they are smoother in on the surface when compared to the oxalates. So again, these can take the shape of stag-on caliculi. They are again radio opaque. When it comes to the uric acid stone, you can always differentiate the uric acid stone very clearly. So these are radiolucent. Always remember, uric acid stones are radiolucent. Any stone can form stag-on caliculi. So uric acid stones can also form the stag-on caliculi. So, but comparatively, the most common ones are the calcium containing stones. That are calcium oxalate and calcium phosphate stones. Leads to stag-on caliculi more frequently. In the cysteine stones, these occurs due to cystinuria. So that is defective reabsorption of cysteine from renal tubules. This leads to acidic urine. Cystinuria is an acidic urine. So again, these are radio-opaque stones. Xanthine stones are very rare. The color is of brick red. This is due to the deficiency of xanthine oxidase enzyme. So other common pathophysiological factor leading to renal stone formation is renal tubular acidosis. So when you talk about renal tubular acidosis, there are three types of RTS. RTA 1, 2, and 3. Of these, RTA 1, renal tubular acidosis type 1, is more common in the formation of renal stones. About 70% of the patients with renal tubular acidosis type 1 present with renal stones. So that is one thing you should remember. Again, in the starting, I have said about infection. So why infection leads to stones? So infective stones formed by infection are primarily composed of magnesium, ammonia phosphate, but they can also contain minute amounts of calcium phosphate in the form of carbonate apatite, which I have said in the starting slides. So what happens here is bacteria here splits the urea, thereby setting upon the condition for stone formation. So Proteus vulgaris is one of the causes of stones, bacteria-induced stones. So Proteus and Canavalis ensiformis. These are the examples of bacteria which has a capability to produce stones. Uh, as a point to remember, you should always remember that struvite stones are more commonly occurred due to bacteria. So of all the stones that we have come across, struvite stones are formed due to bacteria. Just remember it like that. And the most common bacteria are Canavalis ensiformis and what's the other one? Proteus vulgaris. So these struvite stones, they are associated with urinary tract infections. So this is Staghorn caliculi. So this is a cross section of the kidney with dilated pyramids. These are the pyramids. And this is the pelvis, renal pelvis. You can see a large stone impacting the renal pelvis. So this is why we call it as a Staghorn caliculi. So even in the CT, you can see this thing where my cursor is moving. This is the Staghorn caliculi. This is the vertebra. This is the vertebral body. So coming to the clinical features. So as you all know, the main clinical feature is spasmodic pain. The pain will be very excruciating. One of the worst kind of pains a person can come across is renal caliculi. That is called as renal colic. The main pathophysiology is here is what happens and why the pain is so severe is, so there is an obstruction of the urine proximal to the impacted stone. So the pressure is increasing proximally and the stone is being pushed by the pressure. So this causes stretch receptors to get activated, and they in turn activate the pain receptors. So until the stone is passed, this keeps on happening. And the patient lands up in excruciating pain, which leads to vomitings also. So this continuous dilation and stretching of the ureter leads to that kind of ureteric colic. So the patient complains of pain in the loin, that is on the flank. This is generally called as the renal angle. So whenever the patient comes to you with this kind of pain, you'll always palpate the renal angle. look for the renal angle tenderness. In rare cases, the patients may present with hematuria, pain and hematuria. So this is the fourth point is very important, because the stone that is moving is more painful than the stone that is static. So while it is traveling, it activates the ureteric stretch receptors and leads to very excruciating pain. So one of the commonly seen clinical feature is the patient always complains of radiation. So it can be due to the testis or scrotum in the males and labia or anterior thigh in the females. So the differential diagnosis based on the pain are biliary colic. Sometimes if the pain is on the right side, they can mimic the biliary colic. In pyelonephritis, infection of the kidney, this you can differentiate because the patient will have fever. Pyelonephritis, always the patient has high fever, whereas in renal colic, the patient doesn't have a fever. The most common symptoms of the renal colic are pain, radiation to the groin, and nausea and vomiting. These are the common symptoms. There will be sudden onset of pain. The other differential diagnoses are acute pancreatitis, appendicitis, perforated peptic ulcer, epidermolysis. These are some of the differential diagnoses. So one of the side effects. So after the stone gets impacted, the other effect that leads to other diseases, hydronephrosis. So the stone that is impacted in the ureter causes increased urine concentration or increased urine in the proximal to the stone. So here, due to the excessive pressure, hydronephrosis occurs and dilation of the renal pelvis and mm, occurs. This leads to again pain. So hydronephrosis is one of the important thing we should remember. So here you can see this is an ultrasonic image of the kidney. So this is the renal pelvis, and here is a stone, white color, which my cursor is indicating. This is the stone. So there are dilated calyces here. So at this level, you cannot appreciate all these things, but just try to remember. Here is the stone. So in hydronephrosis, there again, depending on the stage, to differentiate the grade of the hydronephrosis. So this, the first one is the normal one, how a callus is present. Normally, it is a cupped in a cupped state. When it is getting dilated in the first grade, it will be of a clubbed type. In the second grade, it is balloon, and third grade, it is crescent shape. These are the three grades of hydronephrosis. Again, important things, anatomical things are ureter always have three constrictors, three constrictions. That is at the pelvic ureteric junction, and the second constriction is at the pelvic inlet. So where it crosses the external iliac vessel. In the third constriction at the where it enters the bladder, that is vesico-ureteric junction. So at these three stages, at these three constrictions, the passage of the stone is a little bit difficult. So whenever the stone is passing through these three constrictions, the patient has a higher chances of getting pain. So while discussing in detail what happens is there is something called as ureteric calculi, but any ureteric calculi is always renal in origin. So that is why we discuss renal calculi and bladder calculi, not ureteric calculi, because ureteric calculi comes from the kidney itself. So in this X-ray, you can see calculi in the left side. So this is a renal calculi. So here, what you see is calculi present in the kidney. This is the calculi, and this thing. Can anyone say what it is? What this thing is? Any guesses? So it is called as a DJ stent. That is double J stent. So it is used to stenting of the ureter, because due to the obstruction of the stone, there is hydroureteronephrosis. To relieve that pressure, you insert a DJ stent into the ureter and facilitate urinary release. This leads to decrease in the pressure, and the chances of progressive hydroureteronephrosis is diminished. Then you can go for stone retrieval or stone retraction or surgery, depending on the type of the stone and size of the stone. So DJ stenting is a therapeutic indication here. So this is a image showing bladder. So this entire thing is the bladder. Here you can see bladder calculi. So bladder calculi is again a different thing entirely. So in brief, bladder calculi, any bladder, there are again two types: primary vesicle calculi and secondary vesicle calculi. Primary is always occurs in the sterile urine. So the primary vesicle calculi, like in the ureter, comes down from the stone that is present in the kidney, that comes down through the ureter and falls in the urinary bladder. There it again grows in size. So that is primary vesicular calculi. Usually they are of again calcium oxalate stones, whereas the secondary vesicular calculi always occur due to presence of infection, and this is the most common type of bladder stone. Usually they occur within the bladder, they do not come from the kidney. So the etiology and pathophysiology, again everything are the same, like the renal calculi. So the other etiological factors other than the renal calculi part, which are only seen in bladder, are the bladder diverticuli. So these diverticuli can act as a storage unit or a factory where stones are produced. So these diverticuli are very important. Always when a patient with a bladder diverticuli will have always a stone present inside it. So because this diverticuli leads to stagnation of the urine, which causes infection. Due to those infections, again phosphate and calcium phosphate stones are common in bladder. This leads to stone formation. Again, other etiologies, BPH. Why does BPH causes bladder stone? The same thing. Any obstruction causes stasis of the urine. So stasis is the most predominant etiological factor. So as the urine cannot be passed through the enlarged prostate, the urethra gets narrowed down. So this leads to stagnation and reflux of the urine. So again, So BPH is the one of the etiological factor. So other thing is the urethral stricture. Again, the pathophysiology is the same thing. So the causes we have discussed just now. Bladder outflow obstruction. Neurogenic bladder is where there is a loss of bladder function. The constriction is gone, so the bladder cannot empty itself. So when the bladder cannot empty, again there is stasis of urine. So these are the various images showing bladder stone. So these are jack stones. Uh, they look something similar to the calcium oxalate stones. So they are calcium oxalate stones happening in the urinary bladder. They are large in size and spiculated on the surface. So there is chance of hematuria. All these things are the ultrasound images of the bladder stone. So here you can see in the bladder jack stone. This is the jack stone, because it has a spiculated surface. So again, the clinical features are pain, but compared to the renal colic, bladder pain is not that severe, because with change in position or movement, the stone gets dislodged. But in walking or standing position, due to the dependent factor of the gravity, the stone gets dislodged and gets attached at the entrance of the urethra. So this leads to pain in some cases, but most commonly renal calculi is very severe pain than compared to the bladder calculi. So another clinical features are this leads to, due to the stasis happening in the urinary bladder, burning micturition due to the urinary tract infection and fever are common clinical features. So the investigations which you do are so the mineral, so you estimate the minerals present in the body. So ESR, serum calcium, phosphate, creatine, blood urea, uric acid, and parathermal levels are usually done. And X-ray KUB is the investigation of choice in the ester years, but not right now. Today, most commonly, you identify the stones using ultrasonography because of its less radiation exposure and very fast diagnosis. And the other things are the intravenous ureterogram and CT abdomen. So the conditions mimicking calculator nephrocalcinosis. This is a calcification of the kidney. It is a nephrocalcinosis is a what do you call it? What do you call it? Not a premalignant lesion, but if you see a patient with nephrocalcinosis, always the patient will develop in the next 10 or 15 years secondary hypertension. So that is one of the indication where predisposing factor for nephrocalcinosis. All this. So other thing is phleboliths. Phlebolith is nothing but a calcification of venous structures in the pelvis. So this presents as a stone. Pancreatic calcifications. All these things can present as a venous stone in investigations. These are all are not indicative for clinical diagnosis, but when you order the patient for an investigations, either an X-ray or an CT scan, these things can be identified. Pancreatic calcification, calcified aorta, nephrocalcinosis, etc. So other differential diagnosis is gallstone. So here you can see appendicolith. Vascular calcifications, etc. Renal tuberculosis again will mimic a renal calculi. All these are important for investigation purpose, because whenever you see this, you should not just go on and say that this is a renal calculi. So that is why I'm depicting all these pictures. So all these things can mimic renal calculi. Renal tuberculosis looks like this. Here, uh, appendicolith can misguide you as a renal calculi. So this is a CT scan showing a renal calculi. Always remember it is a radio opaque, so that is why it is bright in color, that is whitish in color. So here you can see a stone in the ureter. So this is the kidney, and this is the renal pelvis, and this is the ureter. So here you can see a stone. So on the cross section, it is present here, white color thing. So calculi and CT here, both sides, bilaterally it is present. So again, on the sagittal plane, here it is the renal, this is the kidney, and this is the ureter, where you can see a calculi. Usually the ureter won't be of this much of thickness, because on the left side you don't see any ureter here. Only you can see ureter only at this part, but here everything is enlarged because it is a contrast CT where you can see a dilated ureter and a dilated calyx and a dilated pelvis. This is a hydroureter nephrosis present due to the impacted stone. So coming to the treatment, always whenever the stone is of less than 7 mm or 5 mm, always the treatment is conservative. So what we do is, if the patient is in agony, we give a fluid challenge. That fluid challenge is directly we infuse the patient with IV fluids of 1 liter, and we give and what do you call that, smooth muscle relaxants. So this leads to expulsion of the stone, if any present. So this is one type of therapy, and you give injection furosemide about 40 to 60 mg. Stat doses are always uh, direct doses. We do not divide the dose, we give a start dose, and antispasmodic agents to relieve the pain. So this is a conservative therapy. So 90% of the stones which are less than 5 mm gets expelled with this therapy in 3 to 4 days. Some of them get expelled within the first day itself. There are other things where other drugs which we use for stone expulsion. Can anyone say what are those drugs? So that expulsion therapy is called as MET, medical expulsive therapy. So always the treatment when the stone is less than 5 mm is conservative management and medical therapy. When these two fail, then only you go for surgical therapy. So you have tried the flush, that is fluid challenge, but you can't see, but you did not relieve the patient of his pain. Then you go for MET, that is medical expulsive therapy. So what are the drugs that are used here? Can anyone say? I think entire urinary system is already discussed. Already the topic is over. We are repeating again here. Tamsulosin. What is tamsulosin? You are in final year, final semester of your MBBS, and you are going to appear for exam in the next month or in January or February. So what is tamsulosin? It is an alpha adrenergic receptor blocker. So it is used in medical expulsion therapy. So what happens is this leads to relaxing the smooth muscles of the smooth muscles. So the chances of expulsion of a stone is 90%. 90% of the patients gets stone free by the end of 14-day therapy or a 28-day therapy with tamsulosin. So, but there is a side effects. What are the side effects, sir? Retrograde ejaculation is present in males because of the smooth muscle relaxation. When the patient ejaculates, it gets ejaculated into the bladder. One of the side effects of tamsulosin. So then comes the surgical part, where there are three types of surgical modalities. That is ESWL, that is extracorporeal shock wave lithotripsy, with high energy shock uh, placed behind the kidney. This causes the stone to be broken into pieces. These tiny fragments then gets passed through the urine. This is ESWL. Then comes the PCNL, which is widely done and most commonly done surgery, percutaneous nephrolithotomy. Here a nephroscope is passed through the skin and into the kidney. The stone is broken into pieces by the use of nephroscope under vision. Then comes the URSL. So here you go in retrograde fashion, that is through the urethra. Through urethra, using an urethroskop, you go into the bladder, then into the ureter. You pass a basket or a laser device. With laser, you blast the stone, which is again fragmented. If the stone is the fragments are bigger, you use a stone retrieval basket to grab the stone and pass it and take it out. To take it out. So that is these three are most commonly done. Of these three, ESWL is a little bit complicated because there is a chances of injury to the renal parenchyma, and hematuria is commonly seen with ESWL. So of these three, the best one is PCNL and URSL. The open surgery is also done, in where these three options are not available. So here what we do is open pyelolithotomy. We open the urethra at the pelvis and take the stone out. But open procedures are always morbid because it gives an extensive scar of the on the skin. And again there are chances of stricture post-operatively. After 1 or 2 years, the patient can present with stricture of the ureter. So then comes the open nephrolithotomy. This is again opening the kidney. So when the stone is present in the renal pelvis, you go for open pyelolithotomy. When it is in the kidney, in the calyxes, you go for nephrolithotomy. In some cases, where a stone is entirely occupying a pole of the kidney and damaging the calyx, the calyx is already damaged, you go for partial nephrectomy. So that's it. In brief about, I was just revising the topic which was already discussed earlier. So this is a rare image of a X-ray with a child. You don't see these things often because idana cheppandi enduku chodam. Is X-rays indicated in a pregnant females? No, but in extra years or when the investigation warrants the safety of the mother and child, in rare cases we do take X-rays. So, but they are very rare. So this is a X-ray showing a fetus in a pregnant woman. So that is it for today. Any doubts, or do you want me to talk about something else?